Good afternoon, everyone, and thank you for joining us at the California Dialogue on Cancer Surveillance Data Webinar Series. My name is Sheila Senyo Gerhardt. I go by she, her pronouns, Strategic Alignment Specialist for the Comprehensive Cancer Control Program in the California Cancer Registry. Please feel free to introduce yourselves on the chat with your name, pronouns, organization, and where you are joining from. So I'll go over some housekeeping while everyone is typing in your intros. I also want to acknowledge my colleague Joyce Seha, our Coalition Coordinator Specialist, who's playing a key role in today's webinar production. So all participants have been muted, but we will leave the chat or Q&A box open for questions. We'll also have an allotted Q&A after the speaker's presentation. So please stay until the end of the presentation to also participate in a short webinar evaluation. Again, for those who are just joining us, please type in the chat your name, pronouns, organization, and where you're joining from. So the California's Comprehensive Cancer Control Program is a CDC-funded program that provides leadership and coordination of statewide comprehensive cancer control efforts. The Comp Cancer Program leads the Cancer Control Coalition, which is CDOC, and is also required to develop and implement a state cancer plan. So there have been 5 iterations of the state cancer plan, including the 2026-2035 iteration, which is California's first 10-year state cancer plan. So the plan focuses on health equity and prevention to eliminate disparities and improve outcomes. It is still currently in the CDPH approval process, and the plans, once it's approved, will be solely available online. As a background information, these are the cancer plan topic areas for the upcoming 10-year plan. So CDOC works closely with the California Cancer Registry, or CCR, and other partners to implement strategies from the surveillance topic areas. So our goal is to enhance cancer surveillance systems so we can produce and share data in ways that are meaningful and accessible to the public, health organizations, researchers, and other partners. CCR have supported key strategies such as ensuring wider dissemination of cancer data by producing culturally and linguistically appropriate cancer reports. In today's surveillance data webinar, a presenter from the California Behavioral Risk Factor Surveillance System, or BRFSS, the state's largest ongoing survey of adult health behaviors, will highlight new released 2024 BRFSS data, explore how insurance types relate to cancer screening prevalence, and discuss differences in screening patterns by race and ethnicity. Today's presenter, Nick is the research scientist too for the California Cancer Registry. His time is currently dedicated to the behavioral risk factor surveillance system, focusing on activities such as developing fact sheets and reports, the development and analysis of the BRFSS, as well as dissemination of the data sets. Prior to joining CDPH, Nick worked at UC Irvine as an assistant specialist focusing both on the CDC PFAS health study as well as pesticide exposure modeling. Nick graduated from University of California, Irvine with his MPH with a focus on epidemiology, and he also has his MS from the University of California, Riverside in neuroscience. Please welcome Nick Cuvelier.
Thank you so much, Sheila. Let me go ahead and pull up my slides. You see them okay?
It's still on.
I think it's still loading.
Yeah. Can you share your presenter mode?
Yes, let me see. Use presenter, yeah.
I still see the presentation format.
Okay, let me try this one more time.
No worries.
Is that better?
The gray is currently The screen is currently gray.
Okay. Let me see if instead of sharing just the screen, I can share my entire window.
Okay. For folks who are just joining in, please feel free to type in your questions on the chat at any time.
Sorry, is that working better? I don't know.
I still see your notes on I still see the next slide, but does this work for everyone?
It looks good. Just go back, Nick, and
Hmm?
swap the presenter mode. So go back to what you were sharing.
Okay.
Actually.
Here, is it just getting right here?
There
Perfect.
you go.
Okay.
Perfect.
All right. Thank you. All right. Sorry about that. Okay. All right. So thank you all for having me here today. The title is Cancer Screening and Insurance Coverage in California, Insights from the 2024 BRFSS. And I wanted to start with just a little bit of background on BRFSS data and methodology. I know some of you might already be familiar with BRFSS data, some may not be, but I always like to start with just a little bit of background so that people better understand what BRFSS is, when it started, and the advantages of using it as a data resource. From there, I'll go ahead and look at the 2024 cancer screening prevalence. So we'll both look at California for the modules that were available. What did the screening prevalence look like? And we'll compare that to what was seen nationally. And we'll also compare that to what's been proposed for the Healthy People 2030 goals. From there, I'll go a little bit further and look at any potential screening disparities by race and ethnicity. Finally, I'll get into insurance coverage, overall insurance coverage by race and ethnicity, and then look and see any impact that insurance coverage may have when it comes to screening access. And finally, I'll just end with some implications, limitations, and then some things we'd like to do moving forward. Okay. So again, I'll keep this brief, but I like to start with just a little bit, again, overall about BRFSS. So the Behavioral Risk Factor Surveillance System actually started back in 1984. And at that point in time, only 15 states actually participated in that first year. And California was actually one of those states. So we do have data that goes all the way back to 1984 that is available upon request. And the point of BRFSS was to collect data on health risk behaviors. There's always a lot of data being collected on chronic health conditions, but the focus of this survey, we have some of that information as well, but it was really to dig into these behaviors related to risk and some of these behaviors, how they predict chronic disease maybe later on. And BRFSS has changed a lot over time. Initially, it was only focused on landlines. So the survey was conducted via random digit dialing and still is, but in 2011, we actually added cell phones. And there is a possibility we'll be incorporating web-based surveys in the future as well. We just had our national meeting this year, and there have been some pilot studies done that look very promising. So there is a hope that we'll actually be able to incorporate web-based surveys. And I think the data collected by California BRFSS can play a really big role in how we develop policies and programs in California. Again, I think it gives us a unique perspective looking at some of these precursors to chronic health conditions and chronic disease, see what behaviors people are taking part in or what they're not that could be beneficial, and develop an understanding. I think this also helps us to play a more preventative role when we look at public health. And I just like to mention this so people understand how the survey is structured and how we conduct it. But for BRFSS, we always have what's known as the core portion of the survey. This portion is the same across every state, U.S. state and territory that collects the data. There are questions within the core that rotate. And one of the reasons I bring this up is because the cancer screening modules are one of those that rotate, usually on the even years of the survey being collected. Then we have what are known as optional modules. So these modules are actually supported by the CDC, and states can choose whether or not to include them on any given year. So every state can opt into different modules. And then we have state-added questions, which are questions that are specifically added by the state in collaboration with other, usually state programs that answer programmatic specific questions. And these questions actually are not sent back to the CDC. So if you do ever have interest in state-added questions, you would have to go to the state program themselves to request that data. And normally what we do is we run multiple tracks or versions of the survey, specifically to spread out these state-added questions and keep the survey short enough where people are more likely to actually go through and complete the entire survey. If anyone here, after seeing this, if you do have an interest in learning more or would like to take a look at BRFSS data yourself, the code books and questionnaire for all years of data are always available upon request. So I put our email at the bottom here. If you do email us, we're more than happy to share those with you. And if you actually do want to access the data, we have a data use agreement form and a SFTP form. And that allows us to actually get that data to you. We basically set you up with a secure folder where we can transfer you the data. And I've been getting a lot of questions recently, which has been great. Anytime you email us, these don't have to be questions just about obtaining the data. If you do have questions about the survey in general, how it's changed, how to analyze it, the weights, how, the variables that have changed over the years, we're happy to answer any of those questions as well. Okay, so now looking at the 2024 BRFSS data. So I just wanted to give a brief overview of what was included on the 2024 BRFSS. And in total, we had about 8,382 surveys for 2024. And as I mentioned, these cancer screening modules are usually rotating on even years. So they were available for us in 2024. We had cancer screening questions for breast cancer, cervical cancer, colorectal cancer, and lung cancer. For the purpose of this analysis, I did exclude the lung cancer questions only because the numbers that were available for that cancer screening module were low enough that we weren't able to really disaggregate by race and ethnicity or insurance type. So I mainly focused on breast cancer, cervical cancer, and colorectal cancer for this. And I'll go into this a bit more later, but our insurance type was separated into basically three big pools of private insurance, public insurance, or uninsured. All right. And I know this looks very busy. Most of this is actually for your reference if you wanted to take a closer look after the talk. But the three main questions I focused on for cancer screening for this year, again, for breast cancer, cervical cancer, and colorectal cancer screening, these were calculated variables. So these variables were actually calculated by the CDC based on other variables that were in the survey. So I just wanted to give you an idea of how they were collected, what the response types look like, and again, how they were derived. So for example, for the breast cancer screening module, this calculated variable was for women 40 years and older who've had a mammogram in the last 2 years. For cervical cancer screening, this is a calculated variable for female respondents that have had a cervical cancer screening test, either a Pap test or HPV test. And for the calculated variable for colorectal cancer, they include this is for respondents age 45 to 75 who fully met the US PSTF recommendations. And it includes a variety of tests like colonoscopy, sigmoidoscopy, virtual colonoscopy. So, and all those tests obviously have their own adherence protocol for timing. So those are all included in the development of this variable. Okay. So again, the main purpose of this analysis was to, one, just look at the overall prevalence of colorectal, breast, and cervical cancer screening just from the 2024 data. And then we wanted to compare where California stands based on this. So how do our measurements stand up to the what the goals are for the Healthy People 2030 goals, and then also how do we compare nationally if we look at BRFSS measurements across the nation. Then we wanted to look at screening prevalence by race and ethnicity. And finally, again, to look at the effects of the insurance status overall,
Siri,
insurance status by race
what
and,
is the population of California?
sorry? Um, sorry, was that a question? I'm sorry, I didn't hear.
No, sorry. My audio I need to mute.
Oh, okay, no worries, no worries. I just want to make sure. Um, look at the insurance status overall within the population for the 2024 survey. Look at it by race and ethnicity, and then see what, if any, effects the different types of insurance status had on cancer screening. And with that, I'll jump into just starting with the Healthy People 2030 goals. So I looked this up, and the most recent ones I found, breast cancer screening, the goal was to have 80.3% of females aged 50 to 74 who received a breast cancer screening. For cervical cancer screening, the goal was 79.2% of females aged 21 to 65 who received a cervical cancer screening based on the most recent guidelines. And for colorectal cancer screening, it was 72.8% of adults aged 45 to 75, and that's have received a colorectal cancer screening test based on the most recent guidelines. I will mention some of the calculated variables are not a perfect match for this. For the colorectal cancer, I believe it's 1-to-1, so the exact same thing. When these goals were made, I believe this was the recommendation for breast cancer screening was 50 to 74. And I believe now that is 40 years and older, which is what or 40 to 74, which is what the current calculated variable in this study was. Okay. So in comparison, I put down here at the bottom our reference for the Healthy People 2030 targets. And I wanted to see first, how does the national data stack up to these targets? So if we look at every state in all together, so in aggregate, for breast cancer screening, again, women who are 40 years and older who've had a mammogram in the last 2 years, the screening prevalence was at up-to-date screening prevalence was 72.3%. Compared to the target of 80.3. For cervical cancer screening, we did actually have data in California, and unfortunately, I didn't have time to pull all of the data from the CDC website for the national data and analyze it that way. So this is based on the dashboard they have available. And for some reason, I was unable to find the cervical cancer screening rate for 2024 for the national data set. But for colorectal cancer, again, meeting those USPSTF recommendations, it was at 70.8% across the nation. So where does California stack up? Again, based on the same 2024 data. So again, for breast cancer screening, women aged 40 years and older, California stood at 71.3%. So just below what we saw for the national data. For cervical cancer screening, we're unable to compare currently for the national data for 2024, but that was at 64.5%. And for the colorectal cancer screening data, that stood at 65.1%. But what I wanted to do is take a closer look because in each of these categories, obviously this is whoever is up to date. And what I wanted to have a better understanding of is for those who are not up to date, are these individuals who have either never been screened before or people who have been screened and just have not had it done within the recommended time window. So I went ahead and looked, and unfortunately for the breast cancer screening variable, that data was unavailable. But for both cervical cancer screening and for colorectal cancer screening, we were actually able to disaggregate this group. So you can see here in green are those who are up to date. In yellow are those who are out of date but have been screened. But in red is this is the population that has actually the eligible population that has never been screened. And I thought this was interesting. A lot of you may have more insight into this than I do, but for me, it was very surprising to see that the rate for that not up-to-date population, that such a big proportion of them represent people that have never been screened before. And again, at least in my mind, I thought this was a really interesting thing to have a better understanding of, because as we try to continue towards these targets and continue to increase screening rates, having an understanding of how to target those who are currently not up to date, the approach may be different for those who have been seen by a medical provider and they have been screened and just haven't gone back versus those who have actually never had that initial screening in the first place. So again, California is slightly below the national screening rate for breast cancer. I believe it's about 1% difference. And also, California responses, therefore, are also below the Healthy People 2030 goals so far that have been set for 2030. But of interest, again, almost a quarter of those who were eligible for screening have never been screened. So we saw for cervical cancer here, it was at 20% and almost 28% for colorectal cancer. And again, as I mentioned, thinking about how to get people to update their screening, this gives us a little bit of insight into how do we outreach to those populations. Okay. And then what I wanted to do was break up screening by race and ethnicity. And so I know this, again, this figure might be a little bit busy. Across the top here, for breast cancer, you can see I've listed the California overall rate, across the bottom here, you have the rate for California overall. The Healthy People 2030 target is that green dashed line. And what we saw nationally for the BRFSS data was at 72.3%. And I would have liked to disaggregate the racial variables a little bit more. Unfortunately, the N was small enough where I already had to suppress a lot of groups, even on. So I'm trying to think of a good way to explain this, but there's many different race variables that you can use within the BRFSS data. Some are more disaggregated than others, but even using at this level, which is not very disaggregated, we still had trouble with having to suppress a lot of data. But what you can see here, based on what we had available, the screening rate ranged from about 65% up to 74%. And we can see that for those who reported their race or ethnicity as Black non-Hispanic, they had the highest adherence at 74.2%. And those who reported their race or ethnicity as Asian non-Hispanic had the lowest rate at 65.8%. Okay, and so similar data for the cervical cancer screening. Again, this is the percentage of women 21 to 65 who've had a Pap test within the last 3 years or an HPV test within the past 5 years. Again, I don't have the national target here only because I was unable to pull that from the dashboard. But you can see here the Healthy People 2030 target. Again, this dashed line is 79.2%. In our data, those who reported their race or ethnicity as white non-Hispanic had the highest rate at 69.3%. And those who reported multiracial non-Hispanic had the lowest rate at 59.5%. But as you can see too, for the multiracial non-Hispanic group, we have pretty wide error bars there as well. So it might speak to the directionality, but the exact magnitude is a little difficult to tell. All right, and then for colorectal cancer screening. So basically, in this group, again, you have our national and Healthy People 2030 targets on the screen. The highest adherence was seen among those who reported their race or ethnicity as white non-Hispanic at 74%. And the lowest were those who reported their race or ethnicity as Hispanic at 54.5%. All right. So overall, breast cancer screening rates among all race and ethnicities were above 65% for women 40 years and older. And again, overall for California, we are very close to the rate that was seen nationally. Colorectal cancer screening seems to be significantly lower among those who reported Hispanic for their race or ethnicity compared to the other groups. And for cervical cancer screening, I believe the goal for Healthy People 2030 was 70, or I'm sorry, this is colorectal, 79.2%. But unfortunately, in our sample, each group was below 70%. Okay, so then I wanted to get into insurance coverage. And again, look at the population in our sample. What does insurance look like? Insurance status look like across the entire sample, and then see how that plays into cancer screening. So here, these are the raw N, by the way. And for private insurance, this was anyone who had an employer or a union plan or a privately purchased plan. As I mentioned, public health insurance was there's a lot more involved in this one. So we have Medicare, Medicaid, CHIP, VA, and much more. So any public source of health insurance. And for those who were uninsured, again, obviously that was no insurance of any type that was reported on the survey. So overall, when we look at the weighted prevalence, you can see there's a roughly even split between those who had a private health insurance plan versus those who had a public health insurance plan. So at 48.3% versus 44%. And the uninsured rate for California was 7.4%, which is actually very close to what was seen nationally. So the national uninsured rate was at 7.5%. Now, if we look at the uninsured rate by race or ethnicity, we can see that for most groups, the uninsured rate was between 2 and 5%. But we do see that among those who reported their race as Hispanic, this was up to 14.7%. So almost 5 times higher than the next highest group, speaking to the burden of being uninsured is highly concentrated among this group. Again, so we see a roughly even split between insurance types, between private and public health insurance types. The uninsured prevalence for California is actually roughly equal to what we see nationally. And again, it seems like the burden of lacking health insurance is most strongly seen among the Hispanic group. Okay, and then what I wanted to look at is looking at those same insurance types, how basically how do cancer screening rates change across these different groups? And what we can see in most cases, the rates between public and private health insurance were relatively close. So for both mammography, so for the breast cancer screening and colorectal cancer screening, they were about 4% higher for those with private health insurance versus public. The biggest difference we see between those two groups is for cervical cancer screening. So then it increases to an almost 10% difference. And as expected in all the groups, for those who were uninsured, as you would expect, they had a lower adherence to screening guidelines. But I think of interest for both breast cancer and cervical cancer, the rate still remained above 50% for screening. But for those who were uninsured for colorectal cancer screening, this rate dropped below 20%. So being uninsured seems to have the greatest effect on being adherent to the colorectal cancer screening. So again, that colorectal cancer screening number, that shows the most striking difference between those who are insured at all versus uninsured. So at this point, we're seeing that almost 81% of those who are uninsured were not up to date with colorectal cancer screening for this survey. Again, for breast cancer and colorectal cancer, there were slight differences between private and public health insurance, about a 4% difference, slightly higher among those with private health insurance. But the difference was much more stark for cervical cancer, where it jumped to almost a 10% difference. Okay. And again, I know many in this room probably have great insight into this compared to me, but I just wanted to talk about some of the barriers of why people are not up to date with their cancer screening. One of the more obvious, lack of health insurance or a financial barrier. And some of those, even if they do have health insurance, their coverage isn't really sufficient. And that can still lead to very high out-of-pocket costs. There's also potential systemic barriers where someone may have a healthcare provider, but they haven't exactly gotten a clear recommendation that they understand for when they should be getting screened. And even if someone does, they may have health insurance, but the nearest source of medical care is far. It's difficult for them to get to. Going along with that are logistical barriers. Again, lack of transportation if you have somewhere far away, if you don't have reliable transportation, and overall time and work constraints. We know that especially now people are really busy. Finding the time to actually go out and have this screening done can be difficult. And obviously, there are also psychological and cultural barriers. For a lot of people, especially for cancer screening, there's a lot of fear and anxiety over what the test might show and what happens next if they get unfortunate news. There may be embarrassment. Again, a lot of these screening tests can be very invasive, and there can be embarrassment over getting them done. And again, there could be a lack of awareness. For those who do have a healthcare provider, it's possible, again, they haven't been communicated with clearly about when that should be done. And for those who are uninsured, it's possible, much more likely they aren't sure when they should be getting screened. So again, screening rates vary greatly by type, by insurance type, with breast cancer screening showing the highest prevalence and cervical cancer showing the lowest prevalence. As I mentioned, nearly a quarter of eligible Californians in the sample have not been screened for cervical or colorectal cancer. Insurance type seems to be the strongest predictor of colorectal cancer screening compliance. And again, for private insurance, we see that is when it comes to cervical cancer screening, that is the screening type where we see the biggest difference between private versus public health insurance. And overall, the lack of insurance, health insurance burden seems to be most strongly concentrated among the Hispanic community. A few limitations for this analysis. When we do this survey and ask about screening questions, again, what would be really great is understanding why people are not up to date on their screening or why they've never been screened. On the survey, we are able to capture whether they're up to date or not, but we don't have information as to some of those potential limitations for why they haven't been screened. And sample size was relatively small. So again, looking at a single year of data, I wanted to provide the most recent and up-to-date data we have. But for a single year, again, it can make it difficult to disaggregate by certain demographic groups. As you can see, some of them had to be suppressed entirely, and even those that weren't sometimes had relatively large 95% confidence intervals. Insurance categorization was pretty broad when we looked at public health insurance. So again, we included a lot of different types there that serve a lot of very different populations at times. And a single year of data obviously is not going to speak to trends. So even if we see that currently California seems to be below what we see nationally, that's a single year of data. It doesn't tell us if we've been improving over time, or if we've gotten worse, if we've stayed stale. So again, looking at that over time would be very helpful. And that is obviously one of the things I want to do next. So in the future, I would like to do a multi-year trend analysis. I know I presented a little bit on this topic previously, but I would like to combine the last 10 years of data and really take a look at how the rates have changed for this survey for each of these screening types. I would like to disaggregate the types of public health insurance we saw further. As I mentioned, in the public health insurance, we have a lot of different categories, and at times they serve very different populations. So it would be interesting to, depending on sample size, again, look at that a little more disaggregated. And I would also like to, not just for trend analysis, but I'd like to do a pooled analysis where we combine multiple years of data, again, maybe 10 years or so of data, and investigate what we see at the county level. So again, for a single year, it probably wouldn't be too hard to look at a county like LA or San Diego or Orange County, but there are a lot of counties where a single year of data is not sufficient. But it would be really interesting to see how drastically these rates change geographically across the state. And I'd also like to investigate screening in relation to the social determinants of health module and the reactions to race module. Some of the limitations we talked about as to why people may not go and get screened. The social determinants of health module has specific questions on those. And for the reactions to race module, I know they have at least one question based on whether a person feels like they're treated differently when they enter a medical facility based on their race. So I think these are all really interesting modules to add on to this type of analysis as well. And with that, I'll take any questions. Thank you.
Thank you so much, Nick, for your informative presentation on the newly released 2024 BRFSS data. At this time, I'd like to read off some of the questions and comments we already received on the chat. From Dr. Anderson, how accurate is a sample size of 8,382 for the population of California?
Again, this is a random sample taken across California, and can you draw a firm conclusion about the entire state of California from a sample of 8,000? It's probably not perfectly accurate, but I think it gives you an idea. Again, this is a random sample across the state, and I think it's very valuable information to have. And it certainly at least points us in the right directions of things we can investigate further. And in some cases, when we do look over years, especially if we combine, let's say, 10 years of BRFSS data and look at trends, I think it can give us a really good idea of at least whether we're heading in the right direction or not. So, yeah.
It was interesting. Some of your ethnic rates, the confidence intervals all overlap, so there was no significant difference.
Yeah, I think that was one of the downsides of presenting just a single year of data. Again, it's the most recent we had, which is why I wanted to present it. But you're right. I think in some of those cases, I still wanted to present them so that we could get an idea of perhaps the direction of the relationship of screening rates. But the magnitude of the difference is hard to tell with a single year of data for sure.
And then, Stony, you have also another comment. Colorectal cancer screening rates are near 80% in the Medicare population and 44% in the Medicaid insured population. Why are you grouping them together in your analysis?
Yeah, so again, a lot of times I'm doing this because, again, that's one of the future directions is wanting to disaggregate this a little bit further. The reason I grouped it in this case was mostly due to the sample size and being able to disaggregate those more and actually have meaningful data. But absolutely, I mean, overall, I was looking at public versus private versus uninsured, but most of that was due to sample size, which is why I put that. That's definitely a limitation. Like I want to disaggregate that much further, and that'll be much easier to do when we combine multiple years of data as well.
Thank you, Nick. And then from James, have racial and ethnic differences remained consistent since data collection began?
That is something I want to investigate as well. Like that's why I want to do this multi-year trend analysis, looking at race and ethnicity. So again, doing a trend analysis as well as a pooled analysis. What I had here again was just like the most recent data set we had, which I wanted to show. But looking over the recent years, I know at least for the 2022 data, for breast cancer screening, cervical cancer screening, and colorectal, there was a slight increase overall. I have to look and see by race if that holds true as well. I'll have to get back to you on that.
Thanks, Nick. And then, is there a way to quantify the relative impact of these barriers?
That's a good question. A lot of people in this room I know have a lot of insight into this. Quantify in terms of the BRFSS data that we have. We can certainly dig into this a little bit more. Again, I think looking at the social determinants of health, the reactions to race modules, I do think if you're speaking specifically to the barriers, I think some of those are included in those models, and we could look at that and see how big of an impact they have. Absolutely.
And then another comment from Stony. Breast and cervical cancer screening is covered by Every Woman Counts in the uninsured. Colorectal cancer screening is not covered in the uninsured. Please do the multi-year study.
Absolutely. Absolutely. That is the next goal. And I appreciate that. And I know that's why coming here, a lot of you have a lot of knowledge about this, which I get to hear and learn about too. And I know, like, for example, like FIT testing has become a relatively inexpensive way to be screened for colorectal cancer. But yeah, when you have specific efforts, like you said, with Every Woman Counts, and I know they have these mobile mammography vans as well. I know those have made a big difference. So trying to understand all that is something I'm still.
Well, the one thing Every Woman Counts does, it covers it.
Yeah,
They're no
yeah,
longer
that's true.
uninsured. They become insured. They get a 60 days emergency Medicaid or Medi-Cal coverage
Yeah,
to get both breast cancer screening and the workup of the positive exam and the treatment.
yeah.
And we tried to do that in colon cancer, and they said we're not going to ever do that again with a
Okay,
single colon with a single cancer. That's the only one that's going to be done.
okay.
And
So
then
there are very few uninsured. They may be uninsured, but their screening was covered in
Gotcha.
cervical and breast.
Oh, thank you for that.
thank you, Stony. Another question. In terms of social determinants of health, what relevant measures would you look at versus related social needs, for example?
So related social needs, there are in that module, there are questions about having, for example, like a lack of transportation. That's one of them. There are questions about whether I forget the exact question, but about the support you have from family and friends. I think it's very general, like in general. Do you feel like you have someone close to you that looks out for you? Something like that. So I think both of those can speak to some of those logistical barriers about do they have transportation? Do they have people supporting them that are encouraging them to go or helping them get there if they can't themselves? I believe there's like 10 different questions in that module, and I would say like probably 4 or 5 of them could probably speak to some of these barriers in some way.
And then a question from our Cancer Center partner. In addition, any information you might be able to gather in the future that relates to where patients receive their primary care, FQHC versus IHS versus large health systems, etc., would be especially applicable to our work from cancer centers. Just wanted to share in case there is opportunity to explore in the future. Then a follow-up with that one, I'd like to see the addition of free clinics included as well, since a lot of our free clinics are running cancer screening programs in California as they are screening the uninsured population.
No, that's a great idea. I would love to look at that as well. I don't know if we have currently all that information available, but there's always opportunities for, adding questions to the survey. So it's something we can definitely look at moving forward. I think that sounds like a great idea.
All right, I think I covered all the questions on the chat. Are there any other questions for Nick? Okay. I don't see any other comments. Joyce, if you could bring up the last slide. Again, thank you, Nick, for sharing such valuable insights with us today. Please take a moment to complete the short webinar evaluation that my colleague Joyce shared in the chat. So our next webinar will be sometime in the fall, where we will hear from a cancer registry researcher on how to request CCR data and would give CDOC partners a structured walkthrough of the preview requirements, timelines, and submission process. So the recording and slide deck will be shared with you via email as soon as it's available. Thank you all so much for joining us today and see you in the fall. Thanks, everyone.